Good afternoon, everybody. Welcome back to the Winter CPC Seminar. Thanks for joining us, both here in the room and online. I'm delighted today to introduce Dr. Jonathan Klein. He is one of our colleagues here at Stanford over in the med school, and he is a major advocate for adolescent health. And I think one thing we're really excited about is the way he thinks about adolescents in their social context and what that means for things like social media. So please join me in welcoming Dr. Klein.
Thank you, Jeff, and thanks for having me here today. Let's see if does this work. Okay, I'm going to do a couple of things in the next half hour or 40 minutes. I want to take a couple of minutes just to review the way that we in health and medicine think about adolescents and young adults and their development, and then consider some perspectives on well-being and health, and also on literacy as we think about it in health services research. And then take that into a discussion about what is the U.S. agenda, what's the global agenda for trying to make adolescents healthier, and how does that relate to disinformation and misinformation, which as social media folks, I suspect you all have a very clear handle on. But then to talk about what are some of the opportunities and challenges and how can we think about that together going forward. So when we think about adolescents and young adults, we think about the biological, the psychological, and the social transitions that go on there. And the most obvious ones is the physical, biological transition of the child to an adult when it comes to the hormone environment and the physical development. And it's really a time when young people's bodies are changing the most, except for that 0 to 2 year old period of early growth. There's also just as much going on in terms of the brain's growth and cognitive maturation. And there are sort of two milestones there. One that happens around age 14 or 15 when people make the transition from concrete operational thought to formal operational thought. Formal operational thought is when you can think about your thinking, when you can think about the longer term implications of what you're thinking about, rather than just sort of the cause and effect immediate condition. And this is something that not everybody goes through. Some people never develop formal or operational thought, but everybody regresses that a bit when it comes to things that are potentially stressful. So this is why a 14-year-old will tell you, no, I can't get pregnant, even though they are having sex and not using protection, but it just won't happen, right? This is a very concrete response. Or I don't have to wear my seatbelt because I will swerve out of the way if somebody is going to threaten my car because I am that good at my reaction time, right? The second cognitive milestone really happens in the early to mid-20s, the maturation of higher executive function, the ability to make good decisions, the ability to shift your decision-making and to really limit the impulsivity that many younger adults are subject to. And you'll notice that even though we use 18 as the legal definition for many things, that brain maturation continues well into the 20s. So when we think about some of the health risks and behaviors, recognizing that the legal definitions of who's an adult and who's an adolescent and who's able to make a guided decision as opposed to make a good decision on their own really varies. The social interaction piece is also just as important. And the earlier theorists, the Ericksonian psychological theorists, used to talk about going from child dependence to adult independence. Most of the later theorists have recognized very clearly that as adults we are interdependent. We're not actually truly independent when it comes to our families or our relationships or our communities, but there's just as much of a change that goes on in the social development as young people. We're not going to spend a whole lot of time on this. In healthcare, we think a lot about the healthy behaviors and the risky behaviors that people engage in. Bob Haggerty called these the new morbidities, but that was back in the 1950s. So they're like middle-aged to older morbidities at this point, but it's not. It's no longer new when it comes to sort of what we need to worry about in healthcare. Teenagers don't think about their health behaviors and their risky behaviors. They think about their family and their school and their friends and their social environment rather than worrying about the things that we worry about in healthcare. And we're in a situation right now where safety, whether it's in a community or in a school, and what the future prospects for somebody who's been educated are when it comes to the AI innovations in the workforce and the warming of the environment all result in a situation that adds stress to what young people are dealing with. So we have no one definition of what's an adolescent. This just sort of reviews all of the different ways that people have tried to define adolescence. And again, you could start as early as age 10 when it comes to some of the physical pubertal changes, or as late as the late 20s when it comes to some of the social changes. This is a rough picture of what those ages look like, and another way that we often think about it in the healthcare setting is early, middle, and late adolescence. And the things that people are thinking about and dealing about when we see them, whether it's in a healthcare clinical setting or in schools or whatever, in the early adolescence, when the physical changes are very much front and center, is this development of the personal identity. Who am I? You can't think about that without developing that ability to have formal operational thought. In middle adolescence, these changes have happened, and there's a lot of peer group norming. And the driving question is, am I normal? You know, I am walking down the hall, and I know that I have a pimple on my cheek. It is the size of a baseball, and everyone at school is staring at me. This invisible audience that goes on in the middle adolescent years, when in fact, everyone else walking down the halls of the middle school or the high school is thinking about themselves just as much because of the narcissism that's normal at that age. As opposed to the later adolescent period where the question really is, who am I in the world? How do I fit into society? Do I have a meaningful role in my community? And again, where some of the mental health issues that have come to the forefront now are really most central for teens. So on the physical side, there's all this stuff going on in the brain and the hypothalamus and pituitary that affects the testes or the ovaries and causes the hormonal changes. And again, this is also driving some of the brain growth and development. From a psychosocial perspective, again, this peer group identity formation is very much central to that middle adolescent period. The teenage mouse, I can totally get away with this. Getting the cheese, again, that sense of the personal fable of invulnerability. The idealized romance of early and mid-adolescent relationships as opposed to the true intimacy that goes into adult relationships in most cases. And this autonomy and dependence balance that then leads to that independence or interdependence. The guided decision-making, I think, becomes an important issue for us, again, in healthcare, because when you are formal operational, you can be guided through a rational decision. But it doesn't mean that you can get there without some input and some coaching around moderating the executive function and the impulsivity that might still be baked into where your brain is. So let me shift from there to go on to some of the perspectives on well-being and health, and then literacy. So I want to start with and we do a lot of global health work in the Adolescent Medicine Division and in the med school. And I want to start with the United Nations Sustainable Development Goals, because it's important to recognize that up until the COVID pandemic, most of the nations in the world had at least recognized that these were goals that they all were committing themselves to. And the Sustainable Development Goals, which were from 2015 up through 2030, were different from the previous Millennial Development Goals in that they called on all countries to also address disparities within their populations rather than just being focused on the 40 poorest countries in the world. COVID pretty much threw that out the window. Our recent elections have certainly thrown much of the U.S. commitment to some of these goals out the window because of the changes in policy that our administration has taken when it comes to what our role in the world is. Goal 3, good health and well-being, is technically the only one that actually addresses health directly, but you can see many of these address other aspects of social or physical health as well. And if we go back to the WHO Constitution in 1948, the definition that health is a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity gives us that health and well-being component. And there are less known clauses to the WHO Constitution, which I think are useful to remember, that the enjoyment of the highest attainable standard of health is a fundamental right without distinction of a variety of other things, and that governments have the responsibility for the health of their people, which can be fulfilled only by the provision of adequate health and social measures. So the commitment that all of the nations made in the late 40s really would suggest that there is an opportunity for all of our governments to be responsible for the health and social environment of our populations. So let me skip this one, but let me go to this slide, which is a conceptual framework that WHO has put out around what exactly is well-being in that expanded definition of health, and what does it mean to have health and well-being for adolescents and young adults. And so this, you'll notice this came out in 2020. That's a long time from that 1948 definition of health being broader than just physical and mental health. But it has a couple of different domains which I think are worth noting. It has good health and optimum nutrition. It has connectedness, positive values, and a contribution to society. This idea that young people need to be engaged in a positive way in their communities in order to feel connected and to be truly healthy. It has a safe and supportive environment. It has learning, competence, education, skills, and employability. I don't think that's really one domain, but that's how they put it together. But again, it implies the ability to engage with education or vocation and to make that part of someone's well-being. And then it has agency and resilience, the ability to have some control over one's course and future, and the ability to be resilient when that's stressed in some way or another. So this is a view of sort of what is health and well-being in that broader definition. And I wanted to put it out there because as we talk about sort of how does this affect young people and how do we think about healthcare and social media in a way that recognize how they intersect in the people that we're interested in. If you don't have these different elements, you really are not as able to both thrive and achieve full potential in the world. So I also want to look at how do we measure how well people are doing. And in healthcare, we tend to look at what's happening in terms of either things that kill people or things that make their health at risk because of the way they behave. So, for example, this is a slide of current causes of death in children and adolescents in the U.S. Over the last couple of decades. And the top blue line is motor vehicle injuries. And you can see that as they made the cars themselves safer and made seatbelts a more universal practice and airbags universal practice, that the rate of death from motor vehicle injuries fell. And you can also see that orange line that the rate of firearm-related injury rose as we had increasing numbers of guns and fewer and fewer controls on the weapons that were out there. All of the other causes fall down below that, recognizing that for most groups in the population, suicide then becomes the third leading cause of death when it comes to teenagers. But again, this is for all of the children involved. The other way we look at this is the behaviors involved that put you at high risk for some of these things. And this is back when the Centers for Disease Control had data on youth risk behavior readily available on their website, which apparently they will have again soon with some of the variables removed. But this is the CDC's youth risk behavior surveillance system, looking at high school students who were in school during the surveys from the national sample over multiple years. And I'm not going to go through these in great detail, but looking at that, looking at that last column of the 2021 survey, you get some sense of, and I think I went the wrong way there. Let me, of what the rates of some of these are. These are the current use is reporting having used the substance in the last month. 23% of high school students reported having drunk alcohol in the last month. That's actually better. A lot of the substance use dropped during the pandemic. 16% current marijuana use, 18% electronic cigarettes or vaping products. So you can see sort of what the rates of some of these behaviors are, and the places where there are blanks is when they weren't asking those questions in those surveys. This slide looks at some of the sexual behavior, and I always hesitant to put sexual behavior down as a risk behavior, right? Because when you talk to a high school student, they don't say, when I grow up, I'm planning to drive my car into a tree, right? That is clearly a risk behavior that you want to avoid. But most people plan to be sexual as adults. On the other hand, when you look at the way that the behaviors are engaged in, they create a health risk. So we have 30% of high school students in 2021 reporting ever having had sexual intercourse. 21% say they were currently sexually active in the past month, and 52% used a condom as an effective barrier contraceptive or as an effective HIV prevention tool at that last time they had intercourse. So the way that they're doing it is what makes it risky. And in fact, only a third were using effective hormonal birth control or a highly effective method. Only 6% were ever tested for HIV, even though CDC and the American Academy of Pediatrics and other guidelines these days are that there should be universal testing for anyone who's been sexually active. So we have a long way to go when it comes to both getting people to engage in the safe and healthy behavior and also being able to follow the guidelines for care that we say should be out there. This looks at some of the mental health issues, and I think this is where some of the social media questions often come in. 42% of teens in the 2021 survey, sort of at the tail end of the pandemic, report persistent feelings of sadness or hopelessness. 29% say that they have poor mental health. 22%, more than 1 in 5 high school students report having seriously considered suicide. 18% made a plan. 10% actually made an attempt. And only a third of those actually came to care for it. So this is, someone was saying as we were talking before the session, the mental health crisis that we're seeing in the communities. This is national data. CDC also disaggregates this by gender, by race, ethnicity. They used to disaggregate it by sexual identity. We don't know if they're going to still provide that. They used to disaggregate it by the sexual partners as well. But you can see there are some dramatic differences. There are also some differences, which I'm not showing you, by whether the young people feel like they're connected to their school in a way that gives them that sense of positive engagement and positive development. Again, continuing briefly, threatened or injured, didn't go to school because of safety, were bullied electronically is at 16%. It's been stable there for some time. Were bullied at school, ever forced to have sex, had sexual violence. Again, these are significantly high numbers when you think about the lived experience of teens. And it's important to recognize that this is not just the national data. California does the California Healthy Kids Survey. They disaggregate it back to school districts if schools want to. The schools have the option of doing a complete sample of their students and releasing that data or not. Palo Alto School District, for example, released their data, and you can see 7th, 9th, and 11th graders were included in their survey. 16% of the 11th graders, 23% of the 7th graders report having been bullied. Again, looking at alcohol and drug use, chronic sadness and hopelessness, as many as almost a third of the 11th graders in Pali or at Gunn at the high school level here. And again, high numbers having considered self-harm. So I want to put this just for a second up against healthcare utilization, because we think about, well, what can we do about this as clinicians, and are we actually doing what we could be doing to try to prevent some of these outcomes? Only 4 or 5% of all young people were uninsured in 2022. A lot of them had public insurance, Medicaid or Medi-Cal here in California, but people have financial access to healthcare, even if the services are not actually available. And 94% of teenagers report having a usual source of care. Now, for some of them, they report their usual source of care as an emergency room or a school nurse, but most of them have what we would think of as a source of primary care. And if you're uninsured, you don't have a good source. You're much less likely to have a good source of care. When you look at some of the national data on healthcare utilization, the federal data sources show that a little less than half of the adolescents have what the health system thinks of as a well visit, where you would expect the prevention agenda to be much more central to the discussion. When you survey either parents or teenagers, 75% of them think they had a well visit in the last year, and 85+% think they had it in the last 2 years. Because if you went in and they signed the school form, you think you had your checkup, even if it was, you know, I need this form tomorrow, and a fairly cursory engagement. And here's where the gap is that has been part of our agenda in our work, in that the things that adolescents report having actually talked about with their clinicians don't map so well into those risk behaviors. So 57% of the 13 to 14-year-olds, 58% of the 15 to 18-year-olds ever talked about mental health with their clinician at the last visits that they had that they thought were well visits. Again, just about half talked about drugs or alcohol. A lot more talked about school. Very few, 19%, 33% talked about birth control. Again, the numbers don't match where the need is when it comes to whether the quality of care that's going on in these visits is happening or not. About half the teens in the country have never had a private one-on-one conversation with their clinician with nobody else in the room. And if you had that discussion and a private visit, you were more likely to have had some of these discussions about some of the preventable risk behaviors than if you didn't. But even if you had the private or confidential discussion, you still had some major gaps in the content that was being addressed. So let me shift there and talk about how we think about health literacy when it comes to how young people are using our services, how they're thinking about other sources of information when it comes to healthcare. And that will bring us, I think, to the edge of some of the social media discussion, which I'm hoping you all will fill in with the expertise here. So what is health literacy? and I have to apologize because I'm forgetting about my animations here. I will credit the people who've shared their slides with me in a few minutes at the end. But so health literacy is having the personal and social resources that you need to be able to assess, understand, appraise, and use information to make decisions about health. And so you have to be able to communicate, you have to be able to assert what you need, and you have to be able to actually act on this. There has to be a system of care that you can engage with. 47% of adults, 43% of adults, this is in the UK, don't have adequate literacy skills to routinely understand health information. And 61% of adults don't have numeracy skills to understand health information. The numbers are about the same for the US. The theory would be that if we improve people's health literacy, they're able to make better decisions. And everybody in the clinical setting has stories about people who are given medication. For example, the family given liquid amoxicillin for the ear infection who were using the dropper to very carefully measure out the amoxicillin and put it in the ear rather than in the baby. So again, recognizing that we don't always give people the information they need to be able to act on the health information that we think they have. There have been a couple of theories about functional health literacy, sort of being able to read and write. Nutbeam's model of functional literacy, critical literacy, and interactive literacy, which I'll go into in a minute because I like that one a lot. And the issue that there are multiple domains of literacy, scientific or civic or cultural, and that the advent of the internet and social media has sort of added a domain to that. And it sort of goes from, defining risk to defining literacy as an asset over time. And you can slice this a lot of different ways. I think from the purpose of this discussion, functional health literacy is the basic ability to read and write. Critical health literacy is the ability to criticize and to critically analyze the information that you're taking in and to use it to have some control over the life events or situations. And then the interactive literacy, the ability to actually derive meaning from different forms of communication and apply it to different circumstances as a way of really recognizing that without that interactive component, it's hard to take advantage of the critical assessment skills. So just some examples there about, and this is, I think, from earlier in the internet era where if you couldn't spell things, Google didn't know how to help you. But if you don't know what you're looking for or how to spell something near it, it's hard to get the right information. If you don't know how to spell it and you heard about it on TV, how do you make that functional if you want to get more information, and what's the trusted source of that information? The critical piece, do you trust where the information is coming from, and how do you know? Nikki Gray, who's now at Huddersfield in the UK as a health services pharmacist, done a comparative study which showed that in the UK, everybody went to the National Health Service website because you could trust it. Whereas in the US, the adolescents would go to multiple sources and look for either a health facility they recognized or an encyclopedia back when we had those things as a way to validate the sources of information. And then interactive, using the information that you gather from the media, bringing it back to your clinician to test whether what you learned is true and how it actually applies to you in what you're deciding to do. So let's finish up with a little bit about where's the agenda going and what are we going to do about it, and can we do anything about this? So going back to this model and recognizing that investing in adolescent health and well-being not only affects the present health of the young person, but also their future adult health and their children's health. Young parents are at risk for many of the worst outcomes when it comes to the course of pregnancy or early childhood. Um, the UN led a global call to action for adolescent well-being a couple of years ago to engage and empower adolescents as actors in their own advocacy, to try to launch a multi-sectoral, all-of-government response, and to strengthen the political commitment and funding through a global forum for adolescents. Again, this was up against some of the trends that were going on in the world. This was an attempt to recognize that young people were most effective, and also that young people needed to be the agents of change in how some of this actually would happen. This global forum, which was framed as 1.8 billion young people for change, recognizing that that was the world's population of adolescents and young adults in 2023 when this happened, looked to civil society organizations and to national governments to make commitments to improving adolescent health and well-being. And so there were commitments made by, and that's an interesting movement on this slide. I have no idea why it's doing that. Commitments made by international organizations, for example, this one by the International Pediatric Association for both school-age children and later adolescents, calling on all of their national societies to recommit themselves to improving care systems. It led to 24 national governments making commitments, including the U.S. government made a commitment to a Take Action agenda and a call to action for goals for adolescent health, to eliminate disparities, to increase youth agency, to ensure access to safe environments, to increase coordination and collaboration, to strengthen training and support for adults, to improve health information and health literacy, to expand access to care, and to support and disseminate research. The call to action is actually still up on the Office of Population Affairs website. We have a grant to support policy research to support the call to action domains, which they have not withdrawn yet, which we're grateful for. You know, I think we're approaching this in the same way that a colleague who was the president of the American Academy of Pediatrics used to say, let's assume we're starting from the position that neither side wants to hurt the children. And so this, at least, is still the U.S. government's commitment to that global call to action. There are many, many points within it. There are action items within it that clinicians should do, that families should do, that communities should do, as well as what policymakers should do to bring about these goals. They're all unfunded mandates at this point, but they are there's certainly an opportunity to address some of that gap between what we know should happen and what has been happening. And so let me finish with my take on social media, and I realize I'm kind of speaking to the experts here on this, but thinking about social media in the way that we think about health literacy, good social media skills is like learning how to drive. And it has risks. It's not an end, it's a means to an end usually. You have to actually learn the skills, you have to focus on it to do it well. You're in charge of something that can wound or hurt other people. Again, thinking about the cyberbullying reports that we're seeing from the schools. And it's preferably done in a way that you learn to harness the power of the ability to communicate in a way that is positive, and probably shouldn't be done under the influence of substance use or the influence of friends as a sole way to make decisions. Young people need to understand how it works. Information about health and well-being probably ought to be thought differently from information about what clothes to buy. Cross-referencing health information, getting other opinions may be a safer way to approach what you learn about health on the internet or from social media, and recognizing that the commercial determinants of health, whether it's food or tobacco or alcohol or marijuana, are designed to sell products, and helping young people become educated consumers when it comes to recognizing the messaging and commercial determinants rather than health sources. I'm not going to have time to dive into AI and how that may change a lot of what people see or think they see or interpret what they see. But how you train an AI can have a lot of different biases. And I think recognizing that it's not a substitute for individual decision making and trying to understand how and who is really accountable for the impact of it is on the agenda for our society as a whole. Adolescents are particularly vulnerable to misinformation and disinformation. Misinformation is the spread of false information without the intent to mislead. Disinformation is spreading false information with full knowledge of the fact that it's false, with the intention to deceive or cause harm to people. At least that's how I think about it. There are two well-known disinformation campaigns when it comes to the healthcare sector in child and adolescent health. One has to do with vaccines and the misinformation and disinformation campaigns that go into anti-vaccine information. The other one, which in fact has some of the same funding sources behind it as the vaccine disinformation campaigns does, is the current and newer movement against comprehensive sexuality education for young people. And both of them are driven by ideology-driven organizations that are claiming to protect children, even though the evidence is actually in the reverse. So it's an interesting challenge from our perspective in pediatric care. People see pediatricians as trusted sources of information, but educating pediatricians about how and where that information can actually be inserted into this discussion takes a lot of creative thought and takes some resources as well. We can talk more about this in the discussion if you like. So social media can amplify adolescent vulnerability. Impulsivity, sensation seeking leads to more sharing and resharing. Higher sensitivity to reward may make you do things that are more likely to get attention or likes. Again, peer influence is sort of at the heart of social media. Social media as sort of a new super peer when it comes to the development of that independent or interdependent adult identity. And the development of that formal operational reasoning when social media is deliberately seeking to provoke an emotional response makes it harder for people to be critical about how they're responding and why when it comes to the way that young people react to what they see. So there was a Surgeon General report on social media. It had a couple of really nice recommendations. Strengthening the monitoring of researchers can strengthen monitoring of this, can assess and quantify the negative impact of misinformation, can prioritize how this is affecting different groups in the population, and can come up with better strategies to address them. Educators can put in quality literacy programs so that people are inoculated against negative social media influences, and can scale up evidence-based educational programs that build that resilience among children and adolescents. So far, I think only one state has required this. It's a work in progress. There's a model for this that Finland implemented in 2014 following a Russian disinformation campaign, which taught how to be critical in their media diet and being able to recognize truth and fiction online and prioritize critical thinking. And it actually seems to have had some success. At least compared to the other European countries, the Finns ranked at the top when it came to media literacy and resilience to misinformation. And then individuals can learn to identify and avoid sharing misinformation and verify the accuracy, find local strategies to combat it, to engage friends and families, and to listen with empathy and establish common ground and provide alternative sources of information. So I think I'm gonna jump us ahead to the end. I think this is the Take Action Goal 7, which is improving health information and literacy, and just puts that back into like where are we with this Take Action agenda for adolescents. Here are some of the actions that were suggested, and some of the definition of the problem there. So to summarize, we talked about teens' development. We talked about some of the global goals. We talked about multi-sectoral approaches. Talked about why investing in adolescent health is a good thing to do, how risky behavior and literacy interact, and what are some of the activities, both globally and that the U.S. government is supporting that can address this at a community level or at an educational level. So one of my mentors, Dr. Julius Richmond, used to always use this figure about in order to come up with change, you need to have the scientific knowledge, you need to have the social strategies, and then you need to have the political will to be able to implement those changes. And I think we have an emerging body of scientific knowledge here. We have a body of information about social strategies, some of which are proven, some of which are still works in progress. And whether we have the political will to advocate for doing this properly, I think is another work in progress when it comes to the next couple of years. So let me stop there. Let me thank both Ashley Hackett, one of my staff here in Adolescent Medicine, and also Nikki for some of the slides they brought together for this to help me make it ready for you all, and I'm looking forward to the discussion. Thank you. Bring the blue microphone to the chair.
Great. Well, thank you very much, Jonathan. Ben, is everything sounding okay? Great. Really always appreciate getting that kind of high-level view and comprehensive view of what's going on with adolescents. And I want to ask some of the questions about that. They're very selfish in a way, partly because it's always good to get those updates, but I have a 14-year-old daughter, so it's good to be reminded of these things. One of the things that every parent talks to me about and has heard is, as your data showed, adolescents seem to be getting less risky, but there is more self-reporting of mental health worries. There are more hospital reports of attempted self-harm. Could you just try to unpack that a little bit for me? When a parent asks me about these things, it's a bit of a conundrum for me too. So if things are less risky, they're taking less risk behavior, and that's paired with this increase in mental health distress, self-harm behavior, is there separate things going on? Is this part of some larger thing? What might be driving those two things to be happening around the same time? And this doesn't have to be related to social media. Of course you can if you think it is.
No, I think it's a good question. I mean, I think we've seen some effective interventions around some of the legal substance use for adults that has decreased the early initiation. So, tobacco, alcohol, marijuana, which, although they're harmful if you use them as adults, we've had better uptake of restrictions in young people's access. And for the most part, that's been a combination of both effective education and effective point-of-sale control. We still have many, many examples where point-of-sale control fails. The vaping epidemic is a perfect example there. Every high school in America had a very active market for vapes, even though it's completely illegal. And the industry has very clear intent to addict young people, because for a lot of those behaviors, if you don't start them as a teen, you're much less likely to ever engage in them. So from a prevention perspective, there was some effective intervention. I think the the mental health side of that, there was a little bit of a perfect storm around COVID, in that you had social isolation, you had schools closed, you had families disrupted, you had employment disrupted, and I think we're still seeing the late consequences. A lot of the mental health crisis got much, much worse during COVID. It didn't get better after COVID. And so how much of that is sort of the disruption that happened? How much of that is the other things going on in our society that make young people feel less connected? I didn't show the data, but in the California data, they looked at connectedness to school and how it moderates some of the mental health outcomes. And for young people who feel least connected, the mental health rates are way, way up. And for those who do feel connected, they're actually quite a bit better.
Yeah, it seems like a hugely protective factor.
Yeah, so the implications of the part of that is, the secondary screening and intervention, but part of it is also the positive youth development strategies for every school and community.
Thank you. So we've had a couple other people come and talk a little bit about adolescent health. One question that's come up around that increase in mental health concerns, I would love to get your take, is that young people are becoming much more thoughtful and sophisticated around mental health, more willing to talk about it. There could be generational changes there. We see on TikTok there's a lot of engagement with mental health content. Is there any thought in the literature when you're asking adolescents about mental health that there could also be changes in their awareness of it? So I guess the question I have here is, do you have any sense the degree to which perhaps mental health as some sort of is a constant, but the ability to report and think about it is changing, or do you not really buy that argument?
I think that varies a lot depending on the community that one is in. And I think, in San Mateo and Santa Clara counties, there's a lot more social acceptance of dialogues that include discussion of mental health. I think in many, many parts of the country, there's still an enormous amount of stigma involved, and in many different communities, in new immigrant communities, and some ethnicities, it's still very stigmatized to have a mental problem.
Yeah, so it's unlikely that would change that national-wide data.
I think, increasingly we know that there are issues with genetic expression or with the biochemistry of the brain that are what leads to some of the mental health diseases, but people still tend to think that, because it's emotional in its expression, that it should be able to be dealt with just by thinking about it or changing your behavior.
Right. Great, thanks. One of the vectors of concern that's come out recently around misinformation has been misinformation purveyors targeting adolescents because of some of the cognitive development you talked about, so lack of more formal and reasoned thinking. Are there ways in which you or your group have thought about defending young people against those kind of misinformation attacks? Is it like keep them off of social media for a certain period of time? Or are there literacies for, say, I'm thinking 12 to 14-year-olds that perhaps have not developed that, so they are more vulnerable to a misinformation attempt, a manipulation attempt? Or do you have any thoughts, or have people been working on that you know?
So as you know, the Australians are about to launch a great experiment about limiting social media access until you're 16. And Sunny and I were talking before the session started about, would we then have driver's ed but for
Yeah.
social media, and
Right.
how would you make that transition, you know? And I think the other example that comes to mind is it's possible to have well-funded public health messaging that successfully counters the misinformation. And I think the best example we have for that is what used to be the American Legacy Foundation, that then became the Truth Initiative, which was funded by the Master Settlement Agreement between the tobacco companies and state attorney generals, specifically because the industry was shown to have deliberately misled people about the harms of tobacco, and where Truth created the ad campaign, which looked like it was organically driven by young people, and created the counter messaging to the industry, tricking people to becoming addicted. And so it was a very well-crafted set of messages, which was highly effective at helping prevent susceptibility to the industry's pro-tobacco message, which was that smoking was glamorous and adult, and you should do it if you want to be like the people in our ads who are you know, socially successful and athletically successful.
Right.
And so creating that anti-industry lying message was very effective, but it was also heavily funded by those settlement dollars.
Right.
And so the question is sort of where does the counter advertising come from? How do you make sure it's actually effective? And how do you prevent the commercial influences from polluting that message in a way that makes it ineffective or counterintuitive?
Great. Thank you so much. Okay, let's open it up to any questions that the crowd has. Thanks, Sarah.
Hi, thank you for speaking with us. This is a bit of a hot button issue, but you're in the law school right now. There's a case pending before the Supreme Court. It's already been argued, but there's not a decision yet, United States versus Scrimetti, about whether a state law banning gender-affirming care for teenagers is constitutional. And the arguments before the court indicated that there's a pretty big divergence in the medical consensus in different countries about that care and what the standard of care is for trans teens, where it seems that American medical providers are significantly more supportive of gender-affirming care for teenagers than European counterparts. And if that understanding is correct, although maybe it was misconstrued before the court, I'm wondering if you have a sense of why that is.
So let me make a couple of comments about that. One is that the as I understand them, the briefs in that case that have addressed the guidelines have used the UK's interpretation of the evidence as the counter argument to what standards of practice are in other countries. And there is discussion over how much of the global guidelines are evidence-based and how much are consensus-based, lacking any better evidence. I would also note that the UK Health Department's assessment of the risk of electronic cigarettes also diverges completely from everyone else in the world with regard to the benefit or harm that they bring to the population, because they hung that report on a single paper, which was a consensus opinion on the relative value. So I don't know if there's a similar case that went into the UK gender report, but I think that's some of the issues there. I think the other thing, two other comments I'd make about the gender issue. One is that that in general, trying to legislate individual patient care doesn't work very well for individuals who are seeking that care, nor does it work well for the ability of clinicians to make decisions about the care that's needed for an individual for their health needs. And so the issue of privacy and care, I think, ought to supersede the ability of a state to regulate a particular procedure, because in general, state legislatures don't make those decisions based on a complete perspective on medical care or how patients do or don't need that care. The final point I'd make, which I think is especially in light of some of the executive orders that have been issued, is that there will likely be a conflict of laws between both California and New York discrimination laws and some of the federal executive orders on gender care specifically. And what the current Supreme Court will do with the conflict of laws between state laws that say if you don't provide the care, you're discriminating, and a federal order that says you can't provide the care is anybody's guess, but my guess is that it'll take a while for that to play out.
Great, thank you. I think we have time for one more in the back there.
Hi. Is this on? Yeah, okay. My name is Christine, and I actually work with an organization called the Light Collective. We're a nonprofit that's working to advance the collective rights, interests, and voices of patient communities in health tech. And so we recently had HHS issue a bulletin around metapixel tracking, because we noticed that a lot of the HIPAA-covered entities that patients were working with and signing onto were also using metapixel tracking that then went back and sold that information to others. So my question to you on that is, we lost the case in Texas around it. There were certain things that they left in, but we pretty much lost. So my question is, how can social media platforms balance corporate interests with ethical considerations to ensure that AI algorithms do not promote harmful content or compromise the user's privacy?
That's a great question. What would your answer be?
Well, we actually got tasked by the Betty Moore Foundation. We wrote out a AI rights initiative for the U.S. It hasn't picked up traction. Again, the corporate side of it isn't pushing for what we're pushing for. And so, I don't know. We have suggestions. We have a whole document, like a 20-page document with all of the AI systems, how it affects things, vignettes that tell our stories. And we also are facing no funding. The founder of our group does not want to be on Facebook because the group originally started with a BRCA breast cancer group whose information was leaked out. So she refuses to be on that platform. And I don't know. I think there's a huge need for education and awareness, but we can't find funding for that. So I think we have suggestions and solutions in our document, and I'm happy to share it with you as well. But we're kind of at a standstill as we move forward, right? A lot of these people, especially in the patient communities, are focused on just living. And this whole data thing is out of their realm, and they don't want to even bother with it. So that's where our struggle is. And I think it really is around the education and awareness and community building, but that's hard to fund. So.
Thank you.
Yeah, well, I would love to see your document, your suggestions, because I do agree that there's so many challenges with AI, and it's too bad we didn't get a chance to dive more into that. But also some opportunities too, with the way that complexity of information. Is it possible to use some of these tools to help, especially young people, make sense of it?
And I think AI is just the latest version. CVS has known what I buy there for a long time, right? The coupons they give me are based on my past behavior or what they think they can push me towards. And the compilation of cash register tapes from all of the food stores in the country is a data source for commercial activity. So recognizing that, that the interest in selling us things is going to continue, whether it's AI or other, and how do we then think about making sure that it is contained in ways that allow people to maximize their well-being and their health is the challenge on how do you regulate that. And in general, the technology is going to be ahead of the education that's needed on the part of elected officials to make that meaningful.
And can I give you one quick example? I took a break off of social media for a while. My ad targeting, because I work with patient communities across multiple disease states, I was getting ads for funeral arrangements and how to make my body into a tree. And so I stepped away from social media knowing that it was the algorithms, kind of fixed all of that in the back end, but it's still there. So I think considering, they're also taking points of data from everywhere to build your digital footprint.
Yeah, great. Well, thank you. Thank you for sharing that. And thank you, Jonathan, really appreciate you coming. Please join me in thanking him, and we'll see you next week for, do we have next week up, Ben? Sorry. Pardon? Oh, Eleni. Yeah, great. So we'll have Eleni Lenoir over here next week. So please join us then, and thank you once again.
Thank you.
All right.